computer.
Hi, everybody. This is our second debate. It's our second attempt at, I think it's Uromigo Vision is what it's going to become. I don't know, I hope. The first one wasn't very successful, I don't think, is that. And in fact, we had tried to make one of these previously with David, but it was broadly agreed it was a disaster because David was wearing a baseball cap throughout, which was inappropriate attire. So we've decided we'll have a second go at this. It's going to be 10 minutes. We're going to do a renal cancer debate. We're going to do a IMDC good risk patient. So we're going to do a 68-year-old man who had surgery 2 years ago, who's relapsed with 7 metastases, good risk disease, doesn't want and can't have any local intervention, wants some form of systemic therapy. And Brian is going to argue for an IO-VEGF-TKI combination. I'm going to go with single agent VEGF-TKI, the European approach, and David's going to try and come up with something unusual. So Brian, why don't you kick off?
Yeah, thanks, Tom. So thanks for giving me the most easily defended argument in this.
Well, I'm not sure it is. I think that's the problem.
I think IO-TKI is the standard really across risk groups for many reasons, right? I mean, one is just the high tumor shrinkage rate. So response rates, in the 70% range with all the regimens, upwards of 70%. The CR rate for Len-Pembro was 21% in favorable risk. So if you want to use one of David's immune endpoints of complete response rate, it's the highest on the board by far. And progression-free survival hazard ratios down into the 0.4s. Easily tolerated, 3 trials with level 1 evidence. I'd like to give single agent IO to people, but we just don't have the data, right? There's no randomized data. I think Ipi/Nivo is overkill, although I do think a subset of patients are susceptible. We just don't know who they are, and you can't afford progression in the majority of patients.
Brian, the trial you led was the 426 trial. What's the hazard ratio for survival in the good risk patients?
Well, if we want to pick out subsets, we could do that, Tom.
But we aren't talking about subsets. We're talking about good risk.
Subsets.
If you could just give us the result, that'd be great, and we can move
on.
It's
that hazard ratio is 1.17. The Cabo-Nivo is 0.94.
That sounds like one of the hazard ratios of my original trials that I did, Brian, that you've been winding me up about for the last 10 years.
And the 95% confidence interval is broadly covering 1, right?
Okay, but it does sound like it's above 1, doesn't it?
Well, no, the number's above 1, but the 95% I can explain confidence intervals to you if you need to, maybe after the broadcast.
We haven't got time for that. I'm just interested in the number 1.12. And what about the other 2 trials that you referenced? Were their numbers, was it less than 1, or was it above 1?
One was less than 1 and one was above 1, right? Which just shows you in these subsets, you're going to get numbers above and below 1. So and quite obviously, these patients, even when they progress, can go on and get other therapy, right? So they have a longer natural history.
And if we did a meta-analysis of those 3, would the number be above 1 or below 1?
I don't know. I haven't performed that analysis, Tom.
It's going to be above, so it's going to be above 1.
So you're saying that's the only thing that matters?
Well, no, you're just saying it's a subset. And now I'm doing a meta-analysis to try and help you. But it sounds to me like you haven't done the analysis. You haven't done your homework to come to the debate, which is concerning. And in that meta-analysis, the hazard ratio is above 1 for survival. And you've got to admit that's a problem.
I don't think it's a problem, right? Because if you look at all the confidence intervals, they're too small. Even with the meta-analysis, it's not going to be significant.
David,
right?
Do you think it's a problem?
I think it could be a problem if it lasts with more follow-up. To me, the bigger issue is this is the subset where VEGF should perform best. So if VEGF was adding to IO, it should add most in good risk patients, in my opinion. So in some ways, the fact that we don't see plateaus in those survival curves or the PFS curve is to me more concerning than the hazard ratio. But let's wait till we have 5 years of follow-up.
Right. We don't know if we'll see them or not. We don't know if we'll see plateaus.
Is it fair to say that the numbers are going in the wrong direction? When we started, the hazard ratios were less than 1, and now they're going above 1. So the longer we wait, the worse it seems to be getting. Does that worry you?
No, it doesn't worry me.
I agree. Worry?
Nothing really, usually. Well, I agree we need longer follow-up. I agree plateaus are important, but they're not the only important parts of the curve, right? David, you would agree that the early parts where patients are having progression and dying from progression are important as well. So we shouldn't just pick one part of the curve. We need to look at all patients, all parts of the curve.
Yes, I mean, I'm just going to
I'm going to briefly talk about VEGF TKI for a second. I mean, I think I've made my argument at the moment. I totally accept for response and PFS, it's less good to start with. But actually, it looks like that the combination of VEGF TKI and IO is not translating into better outcomes for survival as it currently stands. And with the uncertainty around this, and remember, of course, that the Ipi-Nivo data has been has the 214 trial. The original trial had good, intermediate, and poor risk data, and the good risk patients were excluded because the initial results weren't that great. But the current results for Ipi-Nivo look at least as good as in the good risk population, look at least as good as the other two at the moment. And so you could say, well, there's an inconsistency there. And therefore, as it currently stands, obviously there's less toxicity of a single agent VEGF TKI, and therefore it seems a perfectly reasonable option for patients.
What percent of patients are cured with single agent VEGF TKI?
Well, it's a complicated issue, isn't it? Because
it's not that complicated.
No, it is, because you mentioned the word CR, but you and I have both been arguing that CR is something which we don't think doesn't translate or isn't an endpoint which means cure. So as it currently stands, I'm not sure that there's evidence that VEGF TKI IO is curing more of those patients. We haven't got that long-term data yet.
Well,
so I'm not sure.
Answer the question.
What
percent of patients are cured with single agent TKI?
As it currently stands, the same number as VEGF TKI IO in the good risk patients, because we haven't got 5-year data. You're speculating. You're speculating.
Zero. The answer is zero, Tom. The answer is zero.
The answer for
percent is zero.
And IO is uncertain as things currently stand. Now, David, would you like to enter this debate, or do you just want to walk away? Because I can understand why you say this isn't going to work.
I am enjoying this immensely, just watching. And this is why our last debate went 30 minutes when it was supposed to go 10 minutes. Yes, so I think obviously Brian is right. We need more time, and we shouldn't, we should make big pronouncements over small, small differences. But I would say that to me, for most patients, late endpoints are more important than early endpoints. So if you have a symptomatic patient, patients need a response, and there's no question that VEGF or VEGF PD-1 gets you a better chance at response and a quicker response. But for a regimen to be a true IO therapy, it's got to get better with time. It needs to be like a Bordeaux. IL-2 gets better with time, PD-1, CTLA-4. Those regimens provide better results late. So we see plateaus in those PFS and OS curves at 5 years. For Checkmate 214, as you mentioned, the hazard ratio is improving with time for OS, which is the gold standard. It's now less than 1. Those curves are crossing. Right now, the 60-month OS is 63% for Ipi-Nivo versus 55% for Sutent on that trial. But more importantly, I don't know if we can use the word cure, but remission is certainly possible with modern therapy for kidney cancer. And we all should work to make it more common. And I would argue that pure IO regimens make remission more possible, more likely for a subset, admittedly, for a patient. And that's true synergy. When you're able to stop the treatment and the benefit continues, that so-called treatment-free survival. And in Checkmate 214, not only was treatment-free survival greater with pure IO versus VEGF in the intent to treat, as you guys know, but in the good risk subset, it was 3 times greater with pure IO versus VEGF. Toxicity is certainly greater, no doubt, but I think it's mostly manageable. And quality of life is always going to favor single agent IO. So
I agree with you, David. It's because you are comparing to a non-IO regimen, right? So of course you're going to win on those late endpoints, right? Let me ask one more question before we close to you, David. Do you think there's a role for IO monotherapy in favorable risk? Mike Atkins presented some very intriguing Nivo mono data from HCRN, small subset, all the caveats, but I think response was like 57%, something like that. I mean, really almost unbelievable results in that subset.
Yeah, the data is ridiculously good. It's based on small numbers of patients, but it argues that we need to move away from these clinical determinants of treatment. We need to move towards tissue-based biomarkers like the ones you guys developed during the emotion program with Atezo-Bev. I do think single agent has a role. It's certainly the most tolerable for patients that are unwilling to go through the risk that is added with CTLA-4, or for clinicians who are uncomfortable managing CTLA-4 toxicity, it makes good sense in my mind to try for good risk patients, because those are the patients that have the opportunity to fail first-line therapy and get to second-line therapy. And it's much more important to get PD-1 first than anything else. That's what's preventing patients from dying early with all of these regimens.
Tom, what do you think? You want to put a cap on it?
Yeah,
either David or I has won this debate. Clearly, I know we can debate that, but
yeah, I mean, I'm not sure that's right. So the first thing is we'll put out a Twitter poll on who's won the debate, Brian. I think that's the right thing to do. But number one, before we make any conclusions, I mean, David said obviously I'd lost, which I thought was a bit presumptive, but there we go. But I would like, I think that this is a changing field, and I agree. I just think it's too early to make assumptions. I think it's reasonable obviously it's reasonable to give VEGF TKI IO combinations in this population, and indeed. But for the purposes of debate, I think the pendulum is swinging away from that a little bit. And maybe 2 or 3 years ago, I was much more comfortable saying this is definitely the right thing to do. But if these numbers continue to drift down, we're going to have a debate. And that's what we did.
All right, this was much better than the first one.
Good. I look forward to coming back.
Thanks, David. Brian, nice to see you.
All right, thanks, guys.
Be good.
Bye.